Hello, my name's Rupert Pearce and thank you for watching this short video where we present the findings of the Prism trial, which is an international clinical trial of continuous positive airways pressure as prophylaxis to prevent respiratory complications after major abdominal surgery. Our interest is in the high-risk surgical patient. These are patients who have major surgery, they're often older, they often have comorbid diseases, they often have surgery as an emergency. And we know these patients are much more likely to develop complications and that those complications can have a big impact on the outcomes of their surgery. In this trial, we're particularly interested in the impact of respiratory complications after surgery. We know that anaesthesia for major surgery and surgery itself can have major impacts on the patient's respiratory function after surgery. Operating inside the abdomen, general anaesthesia and muscle relaxants for general anaesthesia can all work together to cause pulmonary atelectasis, pulmonary collapse, which after surgery can lead to pneumonia, respiratory failure, and for many patients they may not survive these complications. We're looking for ways to prevent this problem and to improve patient outcomes after surgery, because we know that it's simply not a case of just surviving to go home after surgery. Those patients who develop respiratory complications and survive to leave hospital will still experience a substantial reduction in life expectancy. So it's important that we find ways to understand and prevent these complications. We know that risk factors such as chronic lung disease, anaesthesia, muscle relaxation, body position, we know that surgical manipulation inside the abdomen, the inflammatory response to surgery, pain after surgery and immobility after surgery all work in concert to promote the problem. So the question is, could we use continuous positive airways pressure, or CPAP, as a way of preventing pulmonary collapse and preventing pneumonia and respiratory failure after surgery to improve patient outcomes? We know in meta-analyses of small trials that there is some evidence that CPAP may prevent pneumonia, and that it may prevent the need for reintubation after surgery, and that it may possibly prevent patients from dying after surgery. But the component trials in these meta-analyses are all relatively small, and there's significant uncertainty as to whether this treatment will genuinely work in the real-world context of major healthcare systems, where there are lots of other things that might challenge the routine use of this treatment. So we undertook the Prevention of Respiratory Insufficiency After Surgical Management trial, or Prism. This is an international trial in 6 countries with 60 hospitals as a clinical effectiveness trial of the value of this treatment in all patients having major abdominal surgery. The trial population were aged over 50 years. We excluded patients who refused consent, who were likely to need invasive mechanical ventilation after surgery, who were pregnant or had an obstetric admission, or who were in already a clinical trial for a similar treatment with a similar outcome measure. The intervention was CPAP for 4 hours after the end of surgery within 12 hours. The minimum CPAP level was 5 centimetres of water, but hospitals each used their own local hospital policies for the treatment and use of CPAP. The comparator group, the control as it were usual perioperative care. We recommended supplemental oxygen, but we discouraged the use of high-flow nasal oxygen as a midway treatment between CPAP and usual face mask oxygen. Our outcome measure was a composite of pneumonia, reintubation or death within 30 days of surgery. Our secondary outcomes were the components of that composite, so individually pneumonia, endotracheal reintubation, death, and also other post-operative infections, mechanical ventilation, and mortality at 1 year. In terms of the statistical design of the trial, it was a 2-arm, simple randomized trial with a sample size of 4,800 patients. We minimized by surgical procedure category and by the country in which the patient was having surgery. We also collected data on various covariates, allowing us to undertake a risk-adjusted analysis that took into account different aspects of the patient and the surgery that may make them more or less likely to experience a pulmonary complication. The trial was sponsored by Queen Mary University of London and it was run with an online database with inbuilt randomization hosted by QMUL. The trial had a national leadership in 6 countries, and it was funded by the UK National Institute for Health Research, Intersurgical, Barts Charity and the Association of Anaesthetists, all of whom we're very grateful for making the trial possible. In terms of trial delivery, the trial slightly overran our target recruitment of 3 years by just 10 months, which overall we're fairly happy with, and the trial progression was very smooth. We had very few problems in terms of trial delivery. In terms of patient recruitment, note that we had very few patients excluded from the trial, and we had very few patients crossing over between trial groups, and that meant that the great majority of patients that we randomised were included in our intention to treat analysis. In terms of baseline data, the groups were very well matched. You can see here a good balance between men and women in the trial, and that you can see here that the majority of patients either underwent hepatobiliary surgery or major colorectal surgery. Also, that there were very few patients who underwent resection of esophagus in this trial, mainly because there's a lack of equipoise amongst surgeons about whether CPAP may cause harm to the esophageal anastomosis. In terms of patient care during the trial, about 2/3 of the patients had some form of neuraxial blockade, be that epidural or spinal anaesthesia, and about 2/3 of the patients were admitted to level 2 or level 3 critical care after surgery. We can also see that very few patients had alternative respiratory support after surgery. A small proportion of patients weren't extubated after surgery and therefore had post-operative invasive mechanical ventilation. A small number of patients had non-invasive mechanical ventilation, and a small number of patients had high-flow nasal oxygen. In terms of the outcomes from the trial, we didn't find any difference between CPAP and usual post-operative care in terms of our primary composite outcome of time to event for pneumonia, reintubation or death within 30 days. And you can see here that there's very little separation at all between the curves for the 2 intervention groups. In terms of mortality at 1 year, we see a similar pattern, and we wondered whether we might see some separation between the groups in terms of mortality later on, but this is not statistically significant. So looking at the tabulated findings for our primary and secondary outcomes, you can see here that the confidence intervals all cross 1 and that there are no significant differences between the groups in terms of any of our primary and secondary outcomes. Of note and of interest for discussion, we can see here that there is an odds ratio of 0.89 for endotracheal reintubation, and we did wonder whether this suggested the possibility of an alternative benefit for CPAP in terms of, for instance, cardiac failure resulting in pulmonary edema. But this is for discussion only because it doesn't represent a significant change in patient outcomes. We also undertook a parallel process evaluation to help us understand how the intervention was used in individual hospitals, to understand intervention fidelity, and why different hospitals may find it easier or more difficult to deliver the trial intervention. We found significant variation between different hospitals in terms of their views about CPAP after surgery. We found that many patients really struggled to tolerate CPAP, in particular because they may have pain or they may have other reasons for feeling uncomfortable immediately after surgery. Hospitals that found it easy to tackle these problems found that they had much higher levels of compliance with CPAP. So it does suggest that there are lots of systems problems within different hospitals that made CPAP a harder treatment to deliver. And we do speculate that this represents the difference between the results of small efficacy trials, where you can imagine that researchers took a great deal of care to select appropriate patients, and they took a great deal of care to make sure that the treatment was delivered as prescribed, as randomized. But CPAP is not as simple as that to deliver in routine healthcare. And the purpose of Prism is to test the value of CPAP in the real-world health system rather than the highly controlled environment of an efficacy trial. So why is Prism important if we didn't show a significant difference between the treatment groups? Well, first of all, CPAP was a treatment that a lot of people felt worked and that would work in the real-world healthcare environment. We now know that that's not the case. And we know that it's not the case because when you try and scale the use of CPAP to a very, very high level for all patients having major surgery, that the complexities of delivering that treatment start to undermine the benefit that it offers our patients. In particular, that results in problems with patient tolerance, especially when patients are in pain. We know that avoiding treatments that are unhelpful, that don't improve patient outcomes, is a good thing to do within health systems, because treatments that don't work can have side effects and therefore can still cause harm. They also have a cost attached to them, and they also distract our nurses and our doctors from treating the patient. And if that distraction doesn't benefit the patient, then it has an overall negative impact both on that individual patient and on other patients around them. So in terms of improving healthcare, we should look to see that as an evolution, not a revolution. And although it's always very attractive to find that individual treatments may have exciting benefits that we didn't recognise before, we know that for most treatments that those benefits are not as big as we would hope once you test them in the real-world health system environment. I'd like to close by thanking every single one of the Prism trial investigators who worked incredibly hard to deliver this trial. I'm extremely proud of all of them, and it wouldn't have been possible without you. Thank you very much.